Good morning, everyone, and welcome. My name is Lisa Flexner. I'm on the leadership team for the Physical Therapy in Mental Health Catalyst, which is sponsored by and housed within the Academy of Leadership and Organization and Innovation within the American Physical Therapy Association. So thank you very much to Ally for your sponsorship and for allowing us to host this webinar series. This is the Lunch Bites webinar series, and this is the fourth in the series. The first three, the webinar series takes place every fourth Wednesday of the month at noon Central Time. So that's 11 o'clock East Coast, noon Central, or sorry, 1 o'clock East Coast, noon Central, 11 o'clock Mountain, and 10 a.m. out here on the West Coast. Our first lunch bite was Can We Even, which was an exploration of scope of practice. The second one was Can We Bill for it, which was obviously whether or not we could get paid to do the work of at the intersection of physical therapy and mental health. And the third was the mind-body connection. Can we ignore it? We are very lucky to have today the brilliant Kelly Bethl. And I'll introduce Kelly in just a moment, but I want to give a shout out to our next webinar, which will be again fourth Wednesday of the month in July. So that's July 22nd at noon Central Time. And Faith Stokes, who is joining us today, will be presenting on trauma-informed care. So that should be a really great session as well. Each lunch bite is just about 30 minutes. And so we're going to get going. Kelly Bethl is here to present for us today. Kelly is a physical therapist, doctor of physical therapy, and a certified yoga therapist. She is a licensed physical therapist with over 30 years of clinical experience in neurologic rehab, oncology, and chronic pain. Dr. Bethl currently serves as adjunct professor at the University of Maryland, Baltimore Graduate School in the Integrative Health and Wellness program, and as a researcher and physical therapist interventionalist at Tidal Health Salisbury, supporting the Arbor Telehealth lower back pain study. Her clinical experience or expertise lies at the intersection of physical therapy and integrative health. Thank you, Dr. Bethl. Take it away.
Helps if I unmute. Hi, everyone. Good afternoon. So, as Lisa just introduced, I'm Kelly Bethl, and I'm a physical therapist. I'm a yoga therapist. I'm also a wellness coach. And today we're talking about the Transtheoretical Model in PT practice. So, this session is designed for PT and PTA professionals and with no prior formal training in behavioral change theory. By the end, I'm hoping that you'll be able to identify 5 stages of it within the transtheoretical model, and also have some basic communication strategies that we can help move our patient from pre-contemplation and actually into action. So here are our objectives today. So why does this matter for PT, and why are we even talking about this? So I'm sure that if I opened up the poll and took a straw poll to see how many PTs, PTAs have given their patients a home exercise program, created a home exercise prescription, scheduled, visits in for patients, how many of them never came back to PT, didn't do their home exercise program, didn't follow through with things. So we actually have both an activity gap and an adherence challenge in rehab. So we know that over 46.3% of adults over 18 don't meet the guideline recommendations for aerobic nor muscle strengthening. And additionally, we're estimating that there is probably about a 50% non-adherence rates to rehab programs, especially home exercise programs. Additionally, it is known that at-risk patients for needing to making some type of behavioral change, whether that is, exercise or something else, really are in the pre-contemplation stage. And another 40% are actually in the contemplation stage. So a majority of our patients may come to us without actually being ready for action. And it's really important to understand here that this non-adherence is not a willpower issue. It's really about readiness. So about only 20% of our patients are ready to move into action when we get them. So, despite also knowing the benefits of physical activity and that behavioral change techniques are beneficial for moving people into action, only about 50 to 75% of healthcare providers incorporate, or I'm sorry, 50 to 75% of healthcare providers do not incorporate behavioral change techniques into their clinical practice. And this is due for a lot of reasons. This can be knowledge, time, confidence. So the Transtheoretical Model, or TTM, gives patients and PTAs a structured way to close that gap. So what is the Transtheoretical Model? So the Transtheoretical Model first showed up in 1983 from James Prochaska and Clara Di Clemente through research on smoking cessation behavior. And the idea was to really create those 300 theories and create a systematic integration of psychological theories and cognitive behavior, psychoanalytic theories, and bring them all together into a model. And so it really was an integration across multiple psychological theories. And why it's important is because it describes how change happens and not simply why. So it's a process, it's not a one-time event. Again, it was originally tied to addiction behaviors, but later expanded to physical activity, nutrition, and chronic disease management. And now it's widely referenced in rehab and health behavior literature worldwide. It is really important to recognize that this model has five core constructs because often people get stuck in that stages of change. We identify where our patient is in for readiness to change in this stage, but often clinicians don't incorporate the other four tenets of this model, and they're just as important. So we have those stages of change. This is where the patients are for readiness. We have process of change. This describes how the change actually happens, and there's 10 strategies for that. There's decisional balancing where patients weigh the pros and cons of changing. There's building self-efficacy. And then in 1997, Prochaska and Valessier actually added temptation, which is the inverse of self-efficacy. So this is what is likely to cause relapse, or patients stop maintaining their behavior. This also paper in 1997 is a seminal paper, and that's where they put all these five constructs together. So what are the five stages of change? So here you see the stages of change. Pre-contemplation is the first, contemplation, preparation, action, and maintenance. And you can see the arrow for progress on one side and then relapse on the other. So it's important to understand that this is not linear, right? It's cyclical. And research confirms that people don't progress smoothly from one stage to another. So they may be in pre-contemplation and all of a sudden they're in, contemplation. Um, Patients can get stuck in these early stages, but they also can go back and forth. So I'm sure we've all had patients where they came in on Monday and they were in action stage and they come back on Tuesday and they're in contemplation stage. So, that it is cyclical. They go back and forth. Um, and the other part of this is that relapse is a part of these stages of change. And so building things into our exercise program, into our long-term goals for these patients so that they maintain these strategies that they've learned in practice is important. We need to actually learn what barriers patients have to continuing this program and making exercise and movement part of their lifestyle as opposed to just something that they did because they went to PT for, 6 visits or 8 weeks or whatever. So let's talk about the stages. Most untreated patients reside in this pre-contemplation and contemplation stage. So pre-contemplation is stage one. This is where they have no intention of changing in the next 6 months. They may not even be aware that they have that there are consequences to their current behavior. They may have tried before and given up. And patients, again, don't even recognize that there is an issue. If they have tried and were unsuccessful in attempts in the past, it is really important that we're working here to rebuild trust. And we'll talk a little bit about some other strategies that we can use in this stage. It's estimated that 40% of at-risk patients are in this change. So here's where you're going to hear, I don't have a problem. My back has always been this way. In stage two, it's contemplation. This is where they're aware that they need a change, yet they're not committed to action. They have to weigh the pros and cons. So ambivalence is a hallmark feature here. In pre-contemplation, the cons far outweigh the cons of changing far outweigh the pros. Here, they're starting to balance out a little bit. So we need to continue to increase awareness. And in here, the patient is ready to make a change in the next 6 months. It's estimated that another 40% of at-risk patients are at this stage. The one thing to realize in these pre-contemplation and contemplation stage is these aren't action stages. So the patient may not be ready for some type of home exercise program. They may not be ready to actually, engage in PT. I work with chronic low back pain, so they're thinking about it, but they may not be ready for it. The next three stages are preparation, action, and maintenance. So preparation is where the action is beginning, is where we start to see taking action. So the patient intends to take action within the next 30 days, and they've started to make some additional steps. They may have made prior attempts and they're trying again. They've joined a gym, maybe they bought sneakers, maybe they reactivated their gym membership, maybe they've actually come to PT. So those are patients where they're ready for action. They're going to start soon. Here it's really, an action-oriented plan really is important here. And then in stage four is the actually action stage, right? So often this is where we start patients by doing it now, but realizing that this is actually the fourth stage in behavioral change is important in this trans-theoretical model. So they begin to actively modify their behavior. They've been doing it for less than 6 months. So there's a high risk for a relapse, and that's fine. Self-efficacy begins to grow, confidence begins to build. Here, it's really important to nurture self-efficacy and provide positive feedback. So in maintenance, they're beginning to make this a habit now. So the behavior is greater than 6 months. They've kept it up. We work to prevent relapse, consolidate gains, but their verbiage now becomes one of this is a habit, this is my lifestyle. It is important to recognize that it is not done, right? When they originally proposed this model, there was a termination phase. And so they realized that not everything should be terminated. Exercise being one of them, right? We want our patients to maintain movement and exercise as part of their lifestyle versus, getting through PT, doing their home exercise program, and then that's the end of it. So in addition to these 5 stages of change, as I said, there are additional constructs that are really important. And one of the constructs is the 10 processes of change. So this is how the patients move from change. So there's a cognitive process and there's a behavioral process. And often we start with that behavioral process in PT, but it's really important to also move our patients through these cognitive phases as well. So we see these early stages, these one in purple, these cognitive stages in the pre-contemplation, contemplation, and preparation stage, right? So these are the early stages. So here, patients are beginning to realize that there is awareness of a problem, that there may be some benefits to changing. There may be dramatic relief, so there may be some emotional arousal. We've had patients who maybe took a bad fall or had a family member that became ill, and the patients are worried that that's going to happen to them. So that motivates them to action. It also can be about hope, right? The patient begins to believe that changing the behavior may be beneficial for them. The environmental reevaluation is how their current behavior affects others. Self-reevaluation, the patient is beginning to reassess their self-image related to the problem. So here, reassessing the value, connecting to their values, connecting to what brings them meaning and purpose is really important in this self-reevaluation page. Social liberation, they begin to seek societal support and norms that favor this healthy behavior. So I always say in some cases, social media could be helpful here. It may also be detrimental depending on what sites they look at and follow and stuff. But here they begin to see that there is support for this healthy behavior. When they move into these behavioral processes, and these are later, more in the prep, action, and maintenance phases, this is when they begin to substitute unhealthy behaviors, such as, parking further away, taking the steps. They seek social support from their families and friends, rewarding themselves for making small gains, and are really important here. Self-liberation. So patients may begin to post on social media their rehab, following surgery, they're in the gym, they're posting every day about their changes. And they also begin to remove triggers from unhealthy behaviors and adding cues for healthy ones. So maybe like using their Apple Watch to remind themselves to stand every hour. It has that little app that says, time to stand. So those are all things that help to move our patients through these stages. So what does this look like? So we can match the process of change to the stages. So we see here that the ones that are kind of highlighted here in purple are the experiential, and we see those again in the pre-contemplation, contemplation, and prep. And here are the different 10 different stages or processes. And then we see how, in preparation, action, and maintenance, we move into more of the behavioral processes. So in addition to those two tenets, there's three other critical constructs in the trans-theoretical model for clinical application. One is decisional balancing, so perceived pros and cons of changing. In that pre-contemplation and contemplation, therapists can help patients identify the pros and cons. They could have less pain, more independence. Con would be, uncertainty of outcome. Money is always, an issue, especially if there's a large copay and things for PT. It is really important that as we begin to try and help support our patients moving from pre-contemplation into contemplation into preparation, that those pros begin to increase. We not only want them to increase, but you actually want to make them have way more pros than cons, because if you have 15 pros and only 4 cons, all of a sudden something like uncertainty of outcome is weighed smaller when you have, it's 1 in 4 versus 1 in 15. So those are something that therapists, and we can talk a little bit about that in a minute. Additionally, self-efficacy needs to build, and that is another role that we as therapists can help support. Obviously, self-efficacy is lowest in pre-contemplation, highest in maintenance. So things like graded exposure, creating achievable goals, small achievable goals, making sure that the goals are in line. We're co-creating the goals with the patient, so we're working on things that they value. And then positive feedback also builds self-efficacy. The 1997 paper from Francesca and Blessier also added temptation. So this is the urge to engage in that old behavior, and it's the inverse of self-efficacy. For us as PTs, what this might look like is, what is going to limit you, or where are you going to what is going to most likely make you skip your exercise. So this kind of gives you some information into temptation, and also helps to begin to inform preventing relapse. And so kind of comes into prevention. How can we keep you going back to those old behaviors? So those are all really important. These three are also really important tenets that need to remember with this trans-theoretical model. So how do we recognize this in clinical practice? There are instruments that can assess it, but really listening to your patients is probably a really informal way. In pre-contemplation, you're going to hear, I don't need to exercise. My pain is just part of aging. My back's always been this bad. I tried before, it didn't work. So there's a lot of resistance, a lack of awareness. It's almost fatalistic. In contemplation, it's more, I know I should, but I've been meaning to start, but my doctor told me I should, but I don't have time. So here we see the ambivalence. It's yeah, but language. Prep, they're starting to plan. They've done initial things. I looked into a gym. I bought new shoes. I found the senior center. I checked out the senior center. In action, they're actually beginning to do the behavior, but it's been less than 6 months. Here they may report that they're actually, had some slips, some may not have done the home exercises program. And this is a great way to start looking at, it's not so much a relapse as it's an opportunity for education and looking at the barriers that are preventing them from doing whether it's exercise, home ex, whatever the prescription is. And then in maintenance, where this is a stable behavior for greater than 6 months. And really the language is about habit. So let's stage match a little bit for the strategies for PTs and PTAs. It's really about having the right message at the right time. So in pre-contemplation, it's about building awareness, not urgency. Motivational interviewing is key at this stage. Active listening is key at this stage. We want to focus on what the patient's goals are. What are their life goals? Education is really important here. This you may want to avoid prescribing exercises prematurely. Again, it depends on the situation. Sometimes, they need to do their home exercise program because it's surgical, pre-surgical because of surgery. But here, know that in this pre-contemplation and contemplation stage, um, you're at risk for them not adhering to the program. In contemplation, we're moving more towards, we still have that ambivalence. So we want to explore it with open-ended questions. What would change? What needs to change for you to feel right or feel ready? Again, motivational interviewing is really important here. We're building rapport, we're raising awareness, we're exploring motivation. And you're going to see a high discrepancy between what the patient's goals is and what their actual behavior is. So again, this is a lot of open-ended motivational interviewing, active listening, non-judgment in these two areas. When we start getting into preparation, this is where it becomes important to co-create an action plan, right? We're supporting the patients in where they in their actual action. So we want to, co-create the plan. We want to help them establish, realistic, achievable goals. Make sure that you have some, short-term goals in there as well that they can celebrate so they see the progress. We begin to identify in this stage potential barriers, and you want to problem solve proactively here. You can ask the patients to commit to a plan on a scale of 1 to 10. How likely are you to follow through with this? When we get into action, we're going to reinforce effort and celebrate small successes, right? Really important to celebrate. Troubleshoot barriers and slips without shame, and watch for signs of relapse. If a patient does relapse or stops doing the home exercise program, it's really important to, using motivational interviewing, using, strategies, help them to identify the barriers and let them problem solve first before you offer support. And so, let them kind of figure out why it may not have worked for them. And then, have them try to problem solve it and then say, may I share with you some other strategies that I've seen work well for some of my other patients. One of the things that I do both in preparation and action stages with my patients is I actually use my home exercise program as my behavioral activation plan. And so when I sit, I do it week to week. So I will sit down with the patient towards the end of the session and say, okay, pull out your calendar. Let's talk about the week. Where can we fit, your exercises in between now and the next time I see you? And that then becomes their behavioral action plan for the week. And then, on a scale of 1 to 10, how likely are you to follow through with this? And that actually problem solves a lot of issues up front. And then when they come back, oh, this worked really well. This didn't work well. This didn't work well. Sometimes the patients need a shorter exercise program. Sometimes they need to break it up into, snacks. So having those conversations really has helped them build it into their lifestyle as opposed to just something they're doing while they're in PT. And then obviously when we get into maintenance, we're reinforcing long-term strategies and anticipating high-risk situations, encouraging, again, peer support and social support. Often maintenance, that's after they're done, they're finished PT. So looking for places to send them to continue movement, whether it's a senior center, a gym program, that type thing, and actually making those connections for them before they wrap up with me. So we're not going to have time to go through all of this, but know that motivational interviewing works really well with the Transtheoretical Model. Motivational interviewing didn't come from the Transtheoretical Model, but they're a great tool to use together. So what does the evidence tell us? There is improvements in adherence we've seen. We know that stage match intervention can help recruit, retain, and see progress in at-risk populations. It helps us to identify readiness for change and individualized goal setting. We know there's also limitations. The evidence is inconsistent. We do not have a lot of evidence to support this tool in the over 60 population, so we definitely need more studies. The problem also is that people often get stuck in the stages and don't include the other parts of the Transtheoretical Model that need to be done for it to be effective. And the other thing too is that Transtheoretical Model works best with one behavior. So if you're trying to get someone to exercise and stop smoking or improve their diet, and exercise, that often there's so many variables in that we haven't seen the results that we have when we work with one single behavior. So in the interest of time, we're going to talk about how we implement this in daily practice. You're going to listen before you prescribe, identify where your patient is, identify the readiness. Ask stage revealing questions on a scale of 1 to 10. How ready are you to make this change? What exercise, how do we make this more possible for you? Individualize, don't generalize. We know that everyone is different, even with the same diagnosis and same comorbidities. Collaborative goal setting is key. We know that. And then normalize, anticipate relapse. They're part of the process, and building ways to work around these barriers and helping patients, support patients for them to problem solve, super important. So our clinical message today, Transtheoretical Model, explains how things happen. Again, it's 5 stages, 10 processes, includes decisional balance, self-efficacy are key. A lot of our patients are not ready to act, so stage matching your approach is critical. Relapse is part of the process. So normalize, anticipate, and help patients cope, build coping plans around it. And then combining the trans-theoretical model with motivational interviewing techniques support behavioral change in our patients. And I think with that, I am out of time. Oh, Lisa, you are muted. I cannot hear
Thank
you.
you so much, Kelly. That was fantastic. Fast and furious, as always,
Always.
with these lunch bites. But of course, the recording will be available on the Ally website or on the Ally YouTube channel in probably in about a week. We do have a couple of questions,
Okay.
and the first one is, do any documentation programs support efficient integration of stages, assessment, and per stage interventions for selected target behaviors?
All right, say that again. I'm trying to find it on the chat here.
Do any
Um,
documentation programs support efficient integration of assessment and intervention specific to the stages that the individual is in and then supported with selected target behaviors?
So I'm probably not the best one to answer that question because I work in research. So I don't have to bill. There are, in pulling this together, there are some documentation pieces that I've seen to incorporate it. I usually just add it in as a note in as I'm writing in about the education that I've worked on with the patient that day. I know when we were talking about this that the plan was to build on this lecture with from someone else. So I think that that will be covered um, later on.
That sounds great. And
Um,
what I would say to all of you listening is if this is of interest to you, for sure, submit those feature requests to your EMR provider, whether that's Prompt or Spry or Athelis or whoever. That should be a fairly easy thing to roll in, at least at a high level. And they're always looking for new features that would support good therapy and good outcomes decisions. The next question is similar to how the stages of grief from Dr. Kubler-Ross was revealed that it's a framework, not an absolute. Not everyone
correct.
moves through the stages
Right.
smoothly. How does that line up with the trans-theoretical model's stages?
I mean, I think, and I'm looking at Mike's question here. The stages of change are a framework. So not everyone's going to go through everything. Not everything is relevant for people. Everyone comes in at a different level and a different experience. And so, I think you have to again um, look at your patient individually. And so everyone is different. And so again, it's a framework. I think for me, one of the bigger takeaways is that we often want to jump as therapists into that behavior end and we forget about the other the purple, the cognitive end. And so recognizing that there are some things that have to happen first and they're not maybe not go through all of them. And again, next time we're talking about trauma informed care. So sometimes that societal pressure is actually a bigger issue because they're looking at, absolute and things that have changed on social media that aren't real, like aren't sustainable. So, I think it's a case by case basis. I think for me, it's realizing that we need those cognitive processes. And again, that this trans-theoretical model is bigger than those 5 stages. And that if we don't include some of those cognitive processes, we're
Mhm.
we're limiting helping supporting our patients through some of these changes.
I think you answered the question from Marilyn, which was a follow-on. But are there standardized timeframes for each phase, or does each person go through at their own
They
schedule.
go through their own pace. And
Yep.
again, I think that's part of the, limitations. They say it's 6 months. Or I've had patients that I've had in pre-contemplation, contemplation, and it's 3 years later before I see them. So I always talk about that I'm planting seeds in that pre-contemplation and contemplation. And no matter how hard I try and how hard I work and pull in all my coaching strategies, that doesn't help. Like they're not there. And 3 years later, they're there. And I've also, in some of the cancer work that I've done, I've had patients say to me, I'm not ready for this. I just want to focus on this right now. And I will come back to this. I recognize that this is a problem. I recognize that I need to be exercising. I recognize that I need to be doing X, Y, and Z. But right now, in this situation, this is all I can focus on. And so I think creating that therapeutic alliance and having a way to actually have a conversation versus me telling you what you need to do and actually working to co-create and have, this motivational interviewing to me is key. That allows me then to address what's really important for the patient. A lot of our patients sometimes just aren't there, and they're making conscious choices as to why they're not there.
And then Sharna asks, how do you discuss this model with your patients, and what is the research about teaching the model to the patients so they're aware of where they are?
It's funny. I don't, that's a really good question. And I didn't actually look at the research on the end of teaching the model to bring, so I can't really address that. Um, I think for me, it's about, again, back to motivational interviewing. So I hear you say that this is a goal for you, but here's where we are. So how do I support you to get to this goal? As opposed to you're not really ready to make change for another 6 months based on what you're saying. So it's about hearing what their goals are and how do I help you move towards your goals? How do I support you in that method? And I think I think the research that I've seen is more in the health coaching end around this model
Hmm.
as opposed to in the PT land around
Yeah.
this model. And so I didn't pull that, to be honest, and so I would have to go back and look at where that is. But a lot of the work that I do, I use my health coaching. I use my wellness coaching, and a lot of, and that is really where I employ those strategies in pre-contemplation and contemplation, because actions as a PT is kind of easy. It's helping realize that, it's helping patients move to that preparation phase. So that is definitely more in the coaching
And
land.
I would second that just in my own experience as a coach. I have trained in the transtheoretical model. I've utilized it both as a coach and as a physical therapist. And in none of my coaching did we say, let's make this visible to the patient.
Yeah, I
So
don't.
I haven't seen any research about it either, about teaching the model to the patients. But I think some patients might resonate with it. Most probably would not.
Yeah, and I think
Um, Go
I
ahead.
would add to that, I don't want it to be a scapegoat. I think sometimes we get stuck in like, oh, well, they're just in the contemplation phase. They're not ready. As I look at it, as I'm identifying the phase, and now I need to help support them to move into action or into preparation. It's not, oh, they're stuck here and oh well. Like, so I use a lot of my coaching techniques in my coaching training in this, especially in that pre-contemplation contemplation. But I've never seen it either where you say, "Oh, you're in the pre-contemplation phase." Um,
Yeah. That is all of the formal questions, and we are, of course, out of time, but we can stay on for a few more minutes if folks have more questions. I have one, which is, and we probably don't know this yet, but that idea of non-adherence is starting to improve with RTM, with remote therapeutic monitoring. And I'm curious how we could maybe use remote therapeutic monitoring to support both adherence and moving through the trans-theoretical model.
it's interesting because there is a little bit of literature on the computers. And so what they were recommending is that it's got to be it's got to be direct. So more of an app versus direct. I do tele-rehab. It's a game changer, for this study. And so, especially because I'm in a rural population that, the access to PTs is 40% less. So I think it's really important. There's, again, depending where people are, but We just switched to MedBridge, and my some of my patients love it because it actually reminds them to exercise. It actually gives them real-time feedback. It gives me real-time feedback. So I think the remote, and again, I don't think we have all the data to actually, show it work, but anecdotally, my patients are finding it useful to have these tools. But I would say it's a hybrid model. It's both. And that is what I've read in the literature that, just giving them an app is not necessarily the best way to go, that it really needs to be individual counseling and face to face, whether I think through, Zoom or through, being in the clinic. But I think it's going to change things.
Excellent. With that, I don't see any additional questions in the chat, but if anyone has any last questions, feel free to put them in. Thank you very much, Kelly, for bringing your expertise and these rich slides. I'm looking forward to watching the recording again to capture even more. Again, the recording will be up on the Academy of Leadership and Innovation YouTube channel probably in about a week. That's typically how long it takes. And our next session will be July 22nd, same time, with Faith Stokes talking about trauma-informed care. Thank you all so much for attending. Thanks to everyone who's watching this on video, and we'll see you next time.